Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. This is Dr. Mohamed Fawzy. I am intensivist working in Security Forces Hospital, Saudi Arabia, and Alexandria University in Egypt. Today we are talking about important topic is recruitment maneuver in COVID-19 related ARDS. The COVID pandemic continue to spread now, reaching over 2.7 million cases with over than 139,000 deaths. Acute respiratory distress considered one of the most important causes of death in COVID-19 patients. About 1 in each 6 COVID-19 patients have difficulty of breathing, and about 40 of those with difficulty of breathing develop ARDS. The estimated mortality is 80% for moderate to severe COVID-19 related ARDS patients. In COVID-19, the virus triggers a severe immune response in their lung. This causes the production of inflammatory molecule called cytokines, which in the severe cases may result in what we name cytokine storm. The lung fill with water and become impermeable to oxygen, causing even mechanical ventilation to fail to rescue this patient. This diagram showing how the severity of the infection, moderate and severe COVID-19, with the level of the cytokines in each level. And here you can see the cytokine storm with alveoli filled of cytokines and inflammatory fluid. How COVID-19 kills? ARDS is triggered by COVID-19, where the lung is filled with inflammatory fluid. So the oxygen is impermeable. So the alveoli will be impermeable to the oxygen, will be failure in oxygenation. In COVID-19, ARDS is an acute syndrome of hypoxia where BF ratio is less than 300 and bilateral lung opacities on imaging not fully explained by cardiogenic causes or fluid overload. This is the ARDS definition, Task Forces 2012. ARDS is not a disease. ARDS has always been a heterogeneous mix of different diseases. Diffuse alveolar damage is often regarded as a key pathological finding in ARDS and is being seen in autopsies of COVID-19 patients. COVID-19 patients have ARDS if they meet the criteria of the Berlin definition, because most of the patients with early COVID appear to have what we name pseudo-ARDS. This is the Berlin definition of ARDS we are talking about. And here you can see also what is the meaning of pseudo-ARDS, where rapidly improving ARDS. Most oxygenation problems that occur on mechanical ventilator are secondary to shunt physiology. The typical treatment of hypoxia from pulmonary shunt is to attempt to recruit collapsed lung unit by increasing and choosing optimum. What is the concept of baby lung in ARDS? The baby lung is a physiological concept, meaning that due to the large amount of non-aerated lung, the remaining normally aerated lung accessible to ventilation is considerably reduced, of similar size as that of the baby. Consequently, the lung compliance is markedly reduced and linearly related to the baby lung dimension, suggesting that the ARDS is not stiff, but instead small with linear normal intrinsic elasticity. So don't forget, baby lung, it is not a stiff lung, but is a small lung with normal elasticity. . One of the most important strategy in the management of ARDS is the protective lung strategy. The landmark ARDS network showing the 25 trial in 2000 showing improved outcome with low tidal volume ventilation strategy between 4 to 6 ml per kg of ideal body weight versus higher traditional tidal volume 10 to 12 milli per kg for ideal body weight. Here RDS here one of the most important point in the management of ARDS is the protective lung strategy with low tidal volume and using of high PEEP for improving oxygenation. Now we are going to talk about recruitment. What is meaning by recruitment of the lung? A recruitment maneuver is a sustained increase in the mean airway pressure with the goal of opening collapsing alveoli of ARDS patient, followed by PEEP to keep the alveoli inflated, which participating in gas exchange. Here diagram showing the recruited lung and the collapsed lung. Again, by another meaning, reopening of the collapsed compliant alveoli or non-collapsed fluid-filled alveoli and keep it open. This is the meaning. What is the mechanism of recruitment maneuver? There are various mechanisms by which recruitment maneuver can be performed, including side breathing, extending side breathing, increased inspiratory pressure and PEEP, sustained inflation, the staircase recruitment maneuver. Currently, minimal evidence to recommend a particular method of recruitment. What is the steps? We are going to talk about one of the recruitment methods, but it is important to be aware that these are not only the method of recruiting the lung and may not be the best method. Before you starting recruitment, you have to be sure about important point. First, you have to keep your patient is paralyzed to prevent any risk of coughing. Ensure the patient is hemodynamically stable, not severely acidemic, doesn't have intracranial pressure, increased intracranial pressure. The method illustrated later, it involves the ventilating of the patient with pressure control. Again, pressure control, 20 centimeters of water above PEEP up to 35 centimeters of water. Here, the steps, we will start by one. First, you have to increase the alarm level of the peak pressure of the PEEP of the airway pressure to 65. Second, increase the FI2 to 100%. Initially, you increase the PEEP gradually. Why gradually? To make sure that patient is hemodynamically stable and tolerating your higher PEEP. So you will increase PEEP to 20. After you reach 20 by PEEP, then shift your patient to pressure assessed control. We'll set an inspiratory pressure of 20 above the PEEP and set the IE ratio to 1:1 to ensure long inspiratory time and increase the longer time and hence a longer time at high pressure airway. Trigger should be changed to pressure triggered and sensitivity set. Now the PEEP is then increased from 20 to 25 for about 30 to 1 minute and then reduced back to 20. Then PEEP increasing should be repeated again to 30 then back to 20, then 35, then back to 20 again. So we'll reach up to maximum is 55 centimeter of water. After the lung have been recruited, now we need to set a beep to keep it inflated. This is a screen from the ventilator showing that we need to reach to beep to 20 first. Should we increase it slowly and gradually to make sure that the patient is hemodynamically stable. Once we reach beep 20, now we change it to pressure control 20 with of course with FI 200%, and don't forget to I ratio to 1:1. Now we'll increase the beep to 25, then back to 20, and we'll increase to 30, to 20, and we'll repeat this process until we reach to beep 35, then we back to. Then now we need to determine how much beep we need to keep the alveoli open. Now we have what is meaning a decremental PEEP trial. There is clearly no point in simply returning to the PEEP level used previously, as this will allow alveoli collapse to recur. Many recommend using a decremental PEEP trial to set a PEEP, arguing that the simpler method of using the ARDS method where PEEP is dependent on the FI2, but doesn't take into account the different lung mechanism of the different patient. The PEEP is gradually reduced while observing ideally the dynamic compliance, not the static compliance. The PEEP is gradually reduced until the PEEP associated with optimal compliance is found, or until there is increase in the PEEP ratio. The aim is to find the PEEP associated with, most important here, with optimal balance between the collapse of dependent area and the over-distension of non-dependent area. This is the most important to find this PEEP. As the PEEP is decreased, the non-dependent part of the lung were becoming less hyperinflated, and the dependent part of the lung were collapsing. However, in order to find the point of maximum compliance, it was necessary to reduce the PEEP beyond this point, which would have allowed more dependent collapse to occur. So we will decrease the PEEP until there is some occurring of alveolar collapse again. Before finally setting the PEEP, it is necessary to recruit the lung again and set PEEP 2 centimeters of water above the value associated with the optimal compliance. This is the most difficult point, so we will say it again. After we reach the maximal compliance, it is necessary to reduce the PEEP beyond this point, okay, which may allow more dependent collapse to occur. So we need again to recruit the lung, okay, and set the PEEP 2 centimeters above the value which previously associated with optimal compliance. Don't forget here, we need high PEEP. What is the role of PEEP in recruitment? PEEP is integral part of protective ventilation structure. The expected beneficial effect of high PEEP is optimizing alveolar recruitment by decrease the intrapulmonary shunt, thus improving the arterial oxygenation, decrease amount of lung tissue exposed to alveolar opening and closing, thus reducing the risk of ventilator induced lung injury. It has been shown that the response to PEEP may differ according to origin of ARDS versus pulmonary or extrapulmonary, the timing, early or late, the localization of infiltration, either diffuse or versus loop, the potential for recruitment, or the subphenotype characterized by particular severe inflammation. What is the level of PEEP needed? The extent of beneficial and deleterious effect of high PEEP vary greatly from one patient to another, and they cannot be predicted from the simple clinical data available at this time. So, a personalized approach is the best, where adjusting PEEP for each patient to optimize his or her alveolar recruitment. However, studies using CT scan have shown that on average the amount of potentially recruited lung is greater when BF ratio measured with high PEEP. Up to date, 3 large randomized controlled trials have compared lower versus high PEEP level. Also, none of them showed a difference in terms of mortality. The pooled meta-analysis found a better survival using higher PEEP in patients with BF ratio less or equal than 200 mm of mercury. Therefore, experts recommend the use of higher PEEP in patients with moderate or severe ARDS. Another recommendation for PEEP in ARDS: PEEP is an essential component of the management of ARDS, and the experts suggest using a value above 5 in all patients presenting with ARDS. High PEEP should properly be used in patients with moderate or severe ARDS, but not in patients with mild ARDS. This is a strong agreement. The experts suggest reversing high PEEP for patients with whom it improving oxygenation without marked deterioration of respiratory system compliance or hemodynamic status. PEEP setting should be individualized. This is the deleterious effect of the high PEEP. When you increase PEEP, increase the end inspiratory lung volume, which affects the hemodynamic, makes hemodynamic worsening, decrease the preload, and increase in right ventricular afterload. And for respiratory risk, increase the risk of volutrauma and barotrauma. Now we have one of the best parameter for the recruitment and PEEP is the pressure volume loop. This is how to monitor the recruitment and dynamic compliance together with optimum PEEP needed and keep away from hyperinflation. We will talk about this. What is the pressure volume loop? It's a physiological tool proposed for diagnostic or monitoring purpose during the mechanical ventilation of ARDS. The reduction in compliance measured by pressure volume curve and the different inflection point on the curve are considered interesting markers for severity and the level opening and closing. Here there is two curves here showing the normal lung and ARDS lung, with here the higher compliance is normal lung and low compliance in ARDS. And this is the upper inflection point, which related to the hyperinflation, and lower inflection point with the minimum PEEP needed for optimum alveolar recruitment. We will talk about it below. below the lower inflection point, there is a little volume change on the ventilation. However, after this lower inflection point, the pressure, the volume and the pressure is rising. Initially, the lower inflection point was thought to be the end of alveolar recruitment, and PEEP have to be set 2 centimeters above this level. So again, the lower inflection point is the end of recruitment, and we are setting the PEEP 2 centimeters above this level. About the upper inflection point, it is the point showing increased airway pressure, no longer increase in the volume. Okay, this makes the over distended. The moment when the increased airway pressure no longer rise in the volume, and it was felt to mark the moment of alveolar over distension. The safe ventilation was bounded between the lower and the upper inflection point. Okay. This is the most safe ventilation area. Is recruitment maneuver is routine in ARDS? It is one of the important questions here. At present, recruitment maneuver cannot be recommended as a part of routine management of patients with ARDS for several reasons. This oxygenation benefit may be short-lived with uncertain significance. There are no studies showing patient outcome benefit. It is uncertain how to differentiate responder from non-responder. There is no evidence for when or how often they should be performed. There is no evidence of reducing ventilator-induced lung injury. The ART trial found increased mortality with staircase recruitment maneuver. So, recruitment maneuver should properly not be used routinely in ARDS patients. Expert made recently a conditional recommendation for using recruitment maneuver in 2017 if hypoxemia is refractory with PF ratio less than 100 despite optimization of therapy, and the recruitment maneuver can be applied in the absence of contraindication. However, since this report, a larger trial using recruitment maneuver followed by decremental PEEP trial to select the PEEP associated with the highest compliance was harmful to the patient outcome. So, recruitment maneuver may be considered as a rescue therapy, but the clinic should be aware there is no clear evidence for its benefit. The mode of recruitment used should be that with which the caregiver is familiar. Several different maneuvers are used, such as application of continuous positive pressure (CPAP) 30 to 40 for 30 to 40 seconds, or the progressive increase of PEEP at contrast driving pressure, or the progressive increase of driving pressure at a constant PEEP. There is no preferred recruitment maneuver. The recommended procedure should at least no longer than 10 to 20 seconds, and the airway pressure should be not exceed 30 to 40 centimeters of water. The recruitment maneuver should be performed with care and should be interrupted if hemodynamic safety is poor. Recruitment maneuvers were evaluated in 8 controlled randomized studies, in total 2,735 patients between 1998 and 2018. In this study, the use of recruitment maneuver was not significantly associated with a reduction in mortality at 28 days. Finally, there is yet no proof optimal recruitment maneuver, notably to minimize the hemodynamic risk and the risk of paratrauma while preserving the efficacy of in term of lung oxygenation. Now, what is the mode of ventilator used in recruitment? There is a lot of ventilator mode used now for promote alveolar recruitment. Here about airway pressure release ventilation, one of the mode for recruitment. ABRV allow patient to breathe spontaneously while receiving high airway pressure with an intermittent pressure release. By promoting spontaneous breathing, it might improve alveolar recruitment to the dorsal caudal region of the lung. Also, arterial oxygenation might be better with airway pressure release ventilation or ABRV. Evidence is still lacking to support the improved outcome, and the potential for the lung injury is of concern. This is a diagram or curve showing the spontaneous breathing with the pressure release and the high beep used for the ABRV. Another mode is high frequency oscillation ventilation. High frequency ventilation is a specialized mode of ventilation where constant mean airway pressure is augmented by oscillating pressure ventilation at a very high rate of up to 900 cycles per minute. Theoretically, this increase in the expiratory lung volume, preventing derecruitment whilst also avoiding overdistension. Still, high frequency oscillating ventilation in the OSCAR study found no difference in mortality when compared with conventional mechanical ventilation ARDS patient. Several systemic meta-analysis of 5 randomized studies, they didn't show significant improvement in gas exchange or reduction in barotrauma with high frequency oscillating ventilation. High frequency oscillating ventilation should be limited to clinical trial in patients with severe ARDS in whom conventional mechanical ventilation has failed despite prone position and should be performed in center with considerable experience of high frequency oscillating ventilation. Recent trial, however, revealed either no benefit or an increased mortality using this ventilator mode. So, high frequency ventilation mode should not be used in ARDS patient. This is a strong agreement. One of the methods to monitor the lung recruitment is the lung imaging. Okay, we are using the lung imaging to ensure how much is the alveoli recruited, or how much amount of the lung have been recruited. This is either by chest X-ray, lung ultrasound, CT, or computed tomography, or western imaging tomography, or electrical imaging tomography, or magnetic resonance imaging MRI. We will give example about them. Ital used chest X-ray to evaluate lung recruitment and found a good correlation with lung recruitment measured by pressure volume curve at 2 different levels of PEEP. What is the limitation of chest X-ray here? Radiography has low sensitivity and specificity as a diagnostic tool, and also the using of the anterior posterior view in SEO. Now we're talking about ultrasound, which can differentiate between the cause of the intravalvular fluid, either it's cardiogenic edema or it's and also can use it in recruitment. And transthoracic lung ultrasound has been used to assess the reduction of non-aerated area during PEEP trial. Significant correlation was found between a decrease in consolidation area and improvement in oxygenation. It showed that PEEP-induced lung recruitment can be adequately estimated with the lung ultrasound using a re-aeration score. What is the limitation of the ultrasound? Cannot differentiate between lung part re-aerated from PEEP-induced and other area of PEEP-induced lung hyperinflation. Now we'll talk about CT. Since 1980, CT was proved a useful instrument to study pathophysiological and radiological pattern of ARDS and can often influence clinical management of patients with ARDS. CT scan allow morphological description of ARDS that includes the recognition of normally aerated lung, poorly inflated area with ground glass ossification, non-inflated area which is a consolidation. Here is diagram showing the aerated area correlation with the airway pressure. Here CT allows a precise definition of lung recruitability, which should be correlated with the setting of PEEP. We can quantify lung recruitment by measuring how much non-aerated tissue become aerated under different ventilatory conditions. Recruitment occurs along the interior volume pressure curve. Here, two CT scan showing the lung with low PEEP and the recruited lung with high PEEP. CT scan also she has limitation which is needed for transporting the patient from ICU to radiological department and its cost and radiation exposure. Despite this limitation, CT scan remains a gold standard technique for the management of patients with ARDS. Now we will talk about what is the advantage and disadvantage of recruitment maneuver. Advantage: improve gas exchange, improve compliance, cheap and quick and easy, can reduce conversion to adjacent like using of ECMO, prostacyclin and oscillation like trial. A disadvantage may require heavy sedation or paralysis. Benefit may be transient, hemodynamic instability which decreasing the preload. Only some disease state respond. Hypercapnia may worsen oxygenation by shunting blood to poorly aerated region. May contribute to ventilator-induced lung injury due to overdistension and the repeated opening of the lung. Risk of paratrauma and pneumothorax. Staircase remodeling may increase mortality in severe ARDS patient. This is the ARDS. Now, what is the evidence for recruitment? The evidence based for recruitment maneuver is conflicting. Extrapulmonary ARDS may be more amenable to recruitment than pulmonary ARDS. Oxygenation benefit found to be short-lived and uncertain long-term significance. No studies showing patient-oriented outcome benefit. Studies confounded by absence of protective lung ventilation. And how to differentiate responder from non-responder is uncertain, and controversies who and when and how often and for how long we need it. We are talking now about the evidence trial. The ART trial published in 2017 found the mortality was increasing with the trial was 2019 was stopped early due to loss of equipoise following the ART trial. The systemic review of recruitment maneuver in 2019 and 2020 that include data from ART and FARP's trials found no improvement in mortality, improvement in oxygenation, reduced use of rescue therapy for hypoxemia, increased rate of hemodynamic compromise, high heterogeneity among those trials which limits the strength of. Now we are talking about the home messages or how to summarize our lectures. Baby lung is not a stiff lung, but it's a small lung with normal elasticity. Recruitment maneuver can be considered in most severely hypoxemic patients. Recruitment maneuver should properly not be used routinely in ARDS. No single method can be recommended. We have alternative simpler recruitment maneuver such as 40 centimeter PEEP for 30 seconds. Maybe preferred to sustain strayer maneuver to increase mortality observed in the ART trial. Recruitment maneuver may be performed by clinical expert in select patient with refractory hypoxemia. Recruitment maneuver improve oxygenation and dynamic compliance. Patient should be monitored for adverse effect for hemodynamic instability, barotrauma, pneumothorax during the performance of recruitment maneuver. Pressure volume loop or curve, the lower inflection point was thought to be the end of alveolar recruitment, and the PEEP have to be set 2 centimeters of water above this level to keep the alveoli open. CT scan remains the gold standard technique for the management of patients with ARDS. Don't forget to stay at home and be cautious about yourself with COVID-19. Thank you.